Now coming to ectopic pregnancy. This is also very, very important. Remember, ectopic pregnancy is pregnancy outside the uterine cavity. The most common site is the fallopian tube, and the most common site in the tube is the ampulla. Why the ampulla? Because this is the widest portion of the tube. It is also the point where fertilization takes place. And usually, ectopic pregnancy happens because of some problem in the tube. The motility is not good, and hence the embryo, which has fertilized in the tube, can't come down to the uterus. Okay, so that the risk factors for ectopic pregnancy usually are something that affects the tube. One of the highest risk factors is a history of a tubal surgery, like the patient has had a tubal sterilization or a tubal recanalization. Second is there's a history of salpingitis. That means the patient has a tubal infection, active pelvic inflammatory disease, or even a history of genital tuberculosis. So one of these histories will usually be given in the question to help you as a clue. It will be given, and you should use these as these clues to help you come to a diagnosis. So tubal surgery, salpingitis, genital tuberculosis, history of IVF. Many times the embryo doesn't implant in the uterus, it goes down and implants in the tube. History of adhesions because of previous surgeries, or history of endometriosis. History of contraceptives, like especially intrauterine devices, increased because IUDs prevent implantation. If they prevent implantation in the uterus, the baby, the fetus might get implanted in the tube. So intrauterine devices, progesterone only pills increase the risk. These are the most, there are a few others, but these are the most important risk factors for ectopic pregnancy, which usually will be a clue in your question. Now, what are we worried about? We are worried about that this ectopic pregnancy might rupture because there is no muscle, there's hardly any muscular layer in the tube as it grows. And usually in the first trimester itself, this is going to rupture. Now, if it ruptures, although that's not the most common thing to happen, is कि अपने आप ही खत्म हो जाता है. But sometimes this can rupture, and that is what we are worried about. So, we are worried about a ruptured ectopic, and a ruptured ectopic in the exam is going to be very easy to diagnose. Why? The patient is going to come with a classical triad of symptoms. What is the triad? A positive UPT or a delayed period, with abdominal pain, with spotting or vaginal bleeding. This is going to be your typical presentation plus signs of shock. That means she's going to have hypotension, tachycardia, she's going to appear pale, there'll be guarding, rigidity. Okay, so all these things will be there. So when you have a patient in shock with the typical triad of symptoms, UPT positive, bleeding, pain, think of ruptured ectopic. Ruptured ectopic is very easy to treat. What do you do in ruptured ectopic? You're not going to waste time in anything. Patient is in shock, shift the patient to the OT and do a salpingectomy. This can be done by laparoscopy or laparotomy, but you have to remove the fallopian tube. That is the treatment of choice. Now, unruptured ectopic is where we have certain signs which are picked up on ultrasound. So, the baby is still in the tube, hasn't ruptured. What are we looking for on ultrasound? So, in ultrasound, you can look at, you might find what is called a pseudosac. This is not a true sac, this is a pseudosac. It's just a collection of fluid in the endometrial cavity. You may actually find the ectopic gestation outside the uterus. You may even see the yolk sac. You may even see the fetus. You may even see the heartbeat. So you actually see the pregnancy outside. You may even see this kind of sign outside the uterus. This is called a bagel sign. This is how a bagel looks like. So the bagel sign, sometimes you don't see the actual bagel. You may just see a random blob. So it's also called a blob sign. You may not see this nice donut sort of thing. You'll just see a mass in the adnexa. This is called a blob sign. So bagel sign, blob sign, pseudosac. And if you switch on the Doppler, you find vascularity all around the sac. This is called the ring of fire sign. These are all signs of ectopic, unruptured ectopic pregnancy. Now, if a patient, I'll just come back to that slide. If a patient comes with these symptoms, positive UPT plus pain plus bleeding, okay, in our mind, we are thinking of three things: abortion, ectopic, or molar pregnancy. If the patient is unstable, patient is in shock, then your diagnosis is quite clear. It is a ruptured ectopic and she requires immediate surgical management. Okay. But if the patient is stable, so you have a patient with these triad of symptoms, UPT positive, pain, bleeding, and the patient is stable, what is the next best step? So this is the how the question will come. Patient has come, she is a 20-year-old girl who's come, her UPT is positive, she's having pain, she's having some bleeding, her vitals are stable. What is the next best step? Next, you will do an ultrasound because it could be an abortion, it could be an ectopic, it could be a molar, it could be either of the three. So on TVS, if you see an intrauterine pregnancy, you are happy. At least you know you have a diagnosis. Or you may see the bagel sign, the blob sign, the actual ectopic in the tube. You may see the ring of fire, the pseudosac. So you know it's an ectopic pregnancy. But many times, especially in the exam, they like telling you that the ultrasound is normal, nothing is seen. So patient is pregnant, UPT is positive, pain and bleeding is there, but ultrasound is normal, nothing is seen, no sac is seen anywhere. This is called a pregnancy of unknown location or undetermined location. And what do you do in this situation? You do a β-hCG and you repeat it after 48 hours. This is called as β-hCG doubling. Now, why is this important? You should know that there is something called a doubling time. That is in a normal intrauterine early pregnancy, β-hCG values increase by more than 60%. So we roughly say doubling, but the rise should be more than 60% in 48 hours. That means if I do a β-hCG today and the value comes as 100, after 48 hours, it should be 200. This is called as doubling. Doubling is actually a misnomer. The rise should be more than 60%. So if it is more than 160, I'm happy. I know this is an intrauterine pregnancy. Maybe it's very early, that's why I can't see it on the ultrasound, and that is what is called as discriminatory zone. This is the level of β-hCG in the blood at which a pregnancy is visible, at which a gestational sac is visible in an intrauterine pregnancy. That means that if the doubling is happening, when do I get a scan for this patient? I will get a scan for this patient when the β-hCG crosses 1500. So to look at the gestational sac on a transvaginal scan, the discriminatory zone is more than 1500. And to look at the gestational sac on a transabdominal scan, the β-hCG should be more than 6000. This is called as discriminatory zone, the level of β-hCG at which a gestational sac is visible in an intrauterine pregnancy. So this is the role of β-hCG. We do it for the doubling time, we do it for looking at discriminatory zone, and these help in management of a pregnancy of undetermined location. So patient comes with positive UPT, pain, bleeding, stable. Next best step TVS non-diagnostic. You can't find anything. Next best step β-hCG doubling. This has come as a question. This has come as a question. Now, ruptured ectopic is very clear cut. This much blood, tube is bleeding. Do a salpingectomy. But unruptured ectopic, like here, you can see the ectopic is here. Unruptured ectopic, what are we going to do? So we have three possible treatment options. Either we wait. Waiting means expectant management because we know majority of ectopics will disappear by themselves. So we just do weekly β-hCGs and wait for the β-hCG to fall. Once it reaches zero, the patient will be fine. है ना? So expectant management उनके लिए करते हैं, not for everybody. This is only for a small group of patients who have no symptoms, okay, whose β-hCG is less than 1000. On ultrasound, the gestational sac size is less than 3.5 centimeters, and where there is no cardiac activity, no heartbeat seen on the ultrasound. Only if these conditions are fulfilled can you put this patient for expectant management in the hope कि अपने आप ही गायब हो जाएगा. But if the patient has a slightly higher beta-hCG, so the patient is stable for medical management, that is giving injection methotrexate. How much do we give? We give 50 milligram per meter square intramuscular, a single dose, or you can even repeat a dose. 50 milligram per meter square intramuscular injection methotrexate can be given to patients who are hemodynamically stable. Patients whose beta-hCG is less than 5,000, whose sac size is less than 3.5 centimeters, again, no cardiac activity, and the patient has no contraindication to methotrexate. She should not be anemic, she should not have thrombocytopenia, she should not have renal disease, she should not have liver disease. That patient you can easily give methotrexate. So stable patient, beta-hCG here, the cutoff we take higher, 5,000, but sac size less than 3.5 centimeter, no cardiac activity, and no contraindication to methotrexate. This is medical management. Surgical management कब करोगे? In unruptured, ruptured में तो we do surgical, but in unruptured, when will you operate? You will operate in an unruptured ectopic pregnancy if the patient has severe pain, so severe symptoms, or is hemodynamically unstable. That means maybe she has started to rupture, or the beta-hCG is more than 5,000, or the sac size is more than 3.5 centimeter, or fetal cardiac activity is present. If any of these are there, you are not going to wait, you are going to operate. Okay, so what surgery will you do? You can do either a salpingostomy or a salpingectomy. I'll just repeat: severe symptoms or unstable patient with very high beta-hCG more than 5,000, with a sac size more than 3.5 centimeter, with cardiac activity present, you will operate. And you will operate, we prefer laparoscopy in unruptured ectopic because it's minimally invasive, and you can either remove the fallopian tube, that is called a salpingectomy, if you're removing the fallopian tube, and this is actually preferred, because if you do a salpingostomy, so laparoscopy is the preferred management, and salpingectomy, removing the fallopian tube, is preferred over a salpingostomy. Salpingostomy kya hota hai? You just give an incision over the ectopic and remove the products. But salpingostomy is like a surgical procedure on the tube. It is a surgical, it will increase the risk of ectopic in her future pregnancies. So that's why salpingostomy is done only if the patient is very, very wanting to conserve the tube, or the family is not complete, then you will consider salpingostomy. But majority of times the salpingectomy is the better way, because it can increase the risk of ectopic pregnancy in the future. Salpingectomy we will definitely advise to those patients whose family is complete. Okay, if this is a recurrent ectopic, if earlier also she had an ectopic in the same tube, again in the same tube, then salpingectomy, remove the tube. That means the tube is damaged. Or ectopic is happened at the site of a previous tubal ligation. That means she had a tubal ligation and ectopic is formed again, then you will remove the tube. Or if it is a grossly distorted tube, that means the tube is grossly looking damaged and it is a huge ectopic, better to remove the tube. So otherwise also salpingectomy, even if it's an unruptured ectopic and you're doing surgery, salpingectomy is the preferred surgery over salpingostomy. You don't want to conserve this tube. Remember, this patient will keep having ectopics.